Is out now. Oh my God. For 2, who's the second one? I hope this is being recorded and being relayed live to Bhopal. Then you don't need to go back home, Dr. Sahu. Okay, fantastic. It's good to see everybody in the morning and a nice crowd. So thank you, Dr. Mishra. Thank you, Akhil, for getting us invited here. And yeah, there's nothing to see actually in that. Okay, so I'll be moderating a session on treating EGFR mutant lung cancer. And when I first saw the topic for this EGFR mutant panel discussion, my first reactions actually were boring. I mean, for the last 5, 6, 7 years, all that we have discussed, is stage 4 NSCLC, Jeftinib doge ki osimertinib doge. Since Sahu is there, dacometinib. Sahu is a big fan of dacometinib. Okay, big fan against dacometinib. Wo doge ki nahi doge. And I was like, everybody will sleep early in the morning. My subsequent reactions of that was, aaj kuch alag karte hain. So alag karne mein, we can also ask the panelists to ask question to each other, and moderator will just look at this. And let's study together and make it interesting. So let's just do that. So I will talk about some conundrums in treating EGFR mutant non-small cell lung cancer. So my first question goes to you, Dr. Anuradha. Dr. Anuradha, do you think, when we used to initially have a look at the report, del-19 was similar to L858. Do you think right now also that is there? Molecularly, is there a difference? First question goes to you. And then to the medical oncologist, will they treat a del-19 versus L858R? And this is an academic session. There is no AstraZeneca, there is no Pfizer, there is no Lilly over here. So first question to you.
Yeah, we still see the same L858R percentage-wise. They're the same as it was earlier. As it
Molecularly, do you think there is a difference between del-19 and L858R?
No.
There is no difference.
Only because of the NGS, we are getting to see the rare mutations on exon 19.
Okay, that's it. But no difference as such far as you are concerned.
In exon 21, we have not yet found any fantastic other.
Dr. Sahu?
Clinically, if I get these reports, yes, 2 years before I used to think all are same, but now I would think of different ways of treating them. I would prefer some drugs in some and some not in others. Like if it's L858R, I probably would be hesitant to start osimertinib on a front line. Because the data, if I look at pure data, I think there is some differential effect in
that pure data is unplanned subset analysis.
I agree.
That pure is a very impure
data. So look at the PFS and look at where the PFS is highest. And the PFS is highest for this group of patients. It's around 18 to 19 months with a VEGF inhibitor
just to counter
versus 14 months. Let me complete.
Yeah,
14 months for osimertinib. And that does make a difference when you speak to the patient, and as a clinician, I think that does make a difference.
Okay. Ashish?
Yes, so both of them are very predictive and even prognostic. But if you look at, when you see this report, the way you actually discuss with the patient, because this is a disease where you're looking at multiple lines upfront. And then when I have an L858R, I'm not that enthusiastic, because I know that within a year, most likely I'll be looking at another option. So the way I probably talk to a patient about L858R, I'll put all the options upfront, maybe even look at combinations, whatever combination, we all know that. And but in del-19, I'm pretty comfortable going with a TKI alone. That's how
del-19 is absolutely okay. L858R, you start thinking in discussing.
Yes, I start being more aggressiwe're not that happy.
Just a small point, Lux Lung, the initial trial showed the preferential activity of afatinib over gefitinib. But when a randomized trial was conducted, there was no difference whatsoever. So, till the time a randomized control trial is there, you can't really be very sure of that. That's one viewpoint. Any other viewpoint? So, will you treat this thing differently?
Both the mutation, as of now, I treat same.
Same. Okay, fantastic.
I will be more worried for, as sir said, about L858R.
Okay.
Both the mutations, I will also be treating the same.
So as far as if I have to summarize, I definitely think that, as Dr. Ashish very rightly said, if you have an L858R, I would definitely say it's a slightly more aggressive disease. We are looking at a second line of treatment within probably 12 months, 14 months. But whether changing a drug in the absence of a randomized control trial, there's a good evidence to show. Ramucirumab plus erlotinib looks better. The dacometinib looks better. but a phase 3 randomized control trial is not there. You may start thinking of that, but if you give osimertinib to them, that's also absolutely okay. So that's one conundrum. Yes, Dr. Sahu, is that okay?
Yeah, giving is totally okay what you're saying, but I think if you look at the data as we look into, there is definitely a tilt towards probably offering the combination, and especially in this case, ramucirumab or a combination at least.
Yeah.
And we never know, like when once Flora 2 comes
Yeah.
and
Once
even
Flora 2 comes, we don't know.
and even in the Tata study, I mean, I would, because we know if you don't give chemo now, many patients will not take it later.
True that.
And
true
something like L858R, I'm too inclined to.
Okay.
Yeah.
Fair. So the next point is uncommon mutations. Let's say you have a G7661Q or a S768I. Is the choice only afatinib? And if I give osimertinib, am I wrong? I'll start with this side of the panel.
Sir, we can use osimertinib
You can
also.
use osimertinib. Next one.
Yes, osimertinib. We
In
can
the
give.
uncommon mutation also.
Yes. we
Okay.
can.
Yes, definitely.
Definitely.
I
Ashish?
think this is, we often break our heads. So first of all, uncommon. Second thing is the VAF would be low. Third is it will be present in biopsy, absent in liquid, or vice versa. So it's a big confusion. If I see the T790M somewhere in the picture,
Forget the
I
T790.
would, yeah. Otherwise, I don't think there is much difference between the two.
So you can give
yeah,
osimertinib
both
also
are
for
probably
that.
the same. Yeah.
Dr. Sahu?
Nothing much to add.
Okay, so this was we had published our data about EGFR mutations, and what we got, we had around 12% of people who had complex or difficult mutations. Most of them had G719X, L861Q, and S768I. We had given afatinib, and the median PFS was around 8.13 months, and the overall response rate was around 60%. This is the data which was, and a lot of people do ask me if somebody comes to you with brain mets, and this was a unicorn data basically on the efficacy of osimertinib in uncommon mutations, and this has just been published in JTO 2022. And here also they have basically said the overall response rate was 61% and duration of response approximately the same. A first study to really show that osimertinib also may act. Again, osimertinib is not FDA approved for treatment of an uncommon EGFR mutation. The only FDA approval for that is for afatinib right now. But yes, based on this study, it may actually get. We'll start, Dr. Anuradha will just stand over there. How common is exon 20 in your, when you report? I mean, how common is this?
It's around 3%.
3%.
Yeah.
So generally what I have seen is, 55% is del19, 30% or 35% is L858R, 10 to 20% are these atypical exon 20s and, other uncombination. So Dr. Sahu, person comes to you with exon 20 insertions. Do you order an NGS or PCR is enough? And are all exon 20 insertions the same?
First thing, I normally nowadays go for NGS. I do the PDL1 and then go for NGS.
Okay.
For the patient, it becomes cost effective and quick also for me. How do I treat these patients? If you till now, I have only 2 or 3 patients experience, and either I've treated with chemotherapy. One patient, I went for double dose of osimertinib. So
Okay, you
yeah.
went for 80 mg BD dose of
Yes,
osimertinib.
yes.
Fantastic.
So I did that. Patient went on for around 18 months, and then we lost
And
the
what
patient.
prompted you to give the 80 mg BD dose?
There is a small data set for
27
the
patients.
osimertinib, and it's not level 1 evidence, but that's the best I could find. I felt could help.
Okay, but so somebody cannot afford osimertinib. What do you start with?
The other 2 patients I started with plain chemotherapy.
Okay, Ashish?
Yes, I think, I mean, I've had few patients only, so experience is limited, but this is a very aggressive disease in whatever limited. And we know immunotherapy probably doesn't work over here. Even so now it'd be fantastic to have a molecular pathologist discussing with you to make decision, as you said, what insertion, what diet. I mean, I personally speaking, for a clinician to follow up all this is just impossible.
Absolutely right.
And
That is why you do friends with molecular
Yeah.
pathologists.
yeah, and as of now, I mean, we would just go with chemo, maybe add an anti-VEGF, and later on, as I mean, I know afatinib doesn't have a very great data, but that's what is available freely. So I have had some experience with that, with stable disease, no great
Nothing great
responses.
over there.
Yeah.
All these very fancy looking drugs about amivantamab, mobocertinib, poziretinib, anybody, I mean, will you try getting them on compassionate basis, or first line treatment will be Ashish is snatching? This is the first time I've seen Ashish getting.
No. So that's what. So
Yeah.
I for those TKIs, I think there is this near and far insertion, and
Yeah.
posiretinib doesn't work and all that. But yeah, we've tried to get it like even, I think Takeda is the company which makes,
Takeda
yeah,
gives
I've
that,
tried,
and
but
J&J goes for amivantamab,
I'm
which
not-
is approved now.
yeah, J&J. And then, yeah, if we find something like this, I've called your team also
Yeah,
for the
and-
trial, but
and
unfortunately,
thank you for that. We have patience
unfortunately,
for
the
that.
trial is
Yeah,
for
it's closed
treatment naive patients.
So again, since we have more questions, standard treatment for a patient of exon 20 insertion is do a PCR confirmed by NGS, see where the mutation is, see where the mutation or deletion is. Some of these exon 20 insertion can still be sensitive to afatinib and osimertinib depending upon the type of deletion or insertion which is there. Also, the first line of treatment will include only and only chemotherapy. Ashish very rightly said immunotherapy doesn't act, no role of giving pembro, pem carbo in that, just give pem carbo in that. The KN regimen also will not really work in this. So just a pem carbo, second line of treatment, you can definitely go ahead with the mobocertinib or amivantamab. Amivantamab is now approved. For all the people who start putting comments in the WhatsApp group, when we had the trial, Papillon trial going on, then there was no patient. At the moment the trial has stopped, everybody has seems to have exon 20 insertion patients. So right now we don't have a trial. We are getting the, I think some other trial in another some time, but right now the treatment, first line treatment will be only and only chemotherapy. On progression, maybe you can give amivantamab over there. So let's start with some more conundrums. And we have a stage 4 non-small cell lung cancer. Sites of mets includes bones, liver, opposite lung nodules, ZEL19 mutant, PDL1 90%. What would you not give? I'll start from here. Their residents. This is just a trick question because they're residents sitting over here. What I mean, there is, and let's say this is a Merck MSG sponsored sponsored session. What will you do? What will you not do?
Will not give immunotherapy.
Fantastic. So I'll just stop over here. Please don't give immunotherapy. Please do not give immunotherapy plus TKI combination. If you give, please be very good friends with a lawyer and have a PI of at least 2 crores. That also may not be able to help you out. So please don't go ahead and give without having a EGFR ALK report at least. Please don't. I mean, this for the residents because a lot of time we have seen second opinions and third opinions people do get. So try avoiding that this thing. Again, our data about EGFR and PDL1, there was some doubt about saying, that PDL1 expression hampers the efficacy of TKIs, but we did not find anything. By and large, PDL1 EGFR doesn't really do anything about that. So, more importantly, I'll go to Dr. Anuradha for this. Stage 4, same, I think, say 50-year-old male, ex-smoker, stage 4 non-small cell lung cancer. Biopsy is showing adenocarcinoma, tissue not sufficient for molecular testing. How commonly do we see all this? Let's start with you. So this side, we will start from you. How commonly in your clinical practice do you see tissue not sufficient? Is tissue still an issue?
Around 10 to 15%.
10 to 15. That's a standard thing. Ashish, do you agree?
No, actually, it's more common than that.
Okay, 20-30%.
More common.
Okay, 20-30%. Okay. So do you then send a liquid biopsy, Dr. Sahu, sitting in Bhopal and or let's say sitting in Delhi, somebody has ordered a liquid biopsy for this patient. What would you say? And the DEL19 has come as a mutant. Will you do this?
So anything that is positive in either of the reports, I will take it. Number
Okay.
one, they are complementing each other, not antagonist to each other.
Okay.
So if your tissue is not sufficient, yes, and you get something on a mutation on liquid, that's a targetable one, you would act on that. And there is data.
So anything positive is positive. That is
Yes.
what you are saying.
So you would get, even if you run concurrently, and Nile has shown you that even if something is negative and you have a positive on one of the tissue or liquid, you would act on that.
Okay, I will start from the Akhil, this side. Abhishek, yeah. So out of this, start treatment on the basis of liquid biopsy report and not do tissue biopsy. If you have a liquid biopsy, DEL19 report from Dr. Anuradha Chogle's lab.
Sir, basically, most of the time, patients, they don't want to go for
No, forget it.
biopsy.
I
But
have, so I'll tell you one thing. Biopsy हो गई, मैंने लिखा है, patient was second opinion के लाया. अब बताओ क्या करोगे?
so biopsy definitely one. If it is positive, then I'll start treating the patient.
You start treating the patient. Will you do a tissue biopsy or not?
We should be doing.
You should be
I
doing.
should be doing.
For what?
Just to see.
You don't trust
for the
EGFR positive was. आपने ही बोला. आपने ही बोला.
Apart from that, I don't.
आपने ही बोला. So I'm asking if you have a EGFR DEL19 positive, what do you want tissue biopsy? See, initially our initial situation, I have ordered, but at that time I didn't trust the lab, I didn't trust the judgment, I didn't have the data. So at that time, I have ordered. We did a concordance study in our own lab. We found out good results. I'll show you the data. And then we said, okay, let's go ahead with that. So I have done it. What is your reason? See, we are fortunate to be sitting inside a tertiary institute which has an in-house lab. I trust my lab. I trust my people. Does everyone trust the liquid biopsy report? That's what I'm asking. That's okay.
If it is liquid biopsy positive, then we start
you
treatment.
start the treatment, but you will still like to do a tissue biopsy. It's okay.
I'll just keep it in mind.
I have done it. It's okay. Okay. Sahu.
So if I got you correctly, you're telling that you have a biopsy of adenocarcinoma,
Ji.
your NGS with the biopsy tissue was not sufficient
Ji.
and the quality did not match and liquid was positive for
Yes.
EGFR. Would I then also insist on
Yes.
before initiating EGFR
Exactly
for a
right.
tissue biopsy?
Yes, sir.
I would not. I would act on the report of the liquid biopsy and go for it.
Okay. Anybody wants to do a tissue biopsy?
So I think the concordance is pretty good. So I mean, to make a diagnosis of cancer, I need a histopathology.
You have the
report.
diagnosis.
Okay, and then if I have liquid biopsy, I'll agree with Dr.
Sahu.
Sahu.
Okay,
Yeah.
fantastic. Dr. Anuradha?
As you have rightly mentioned, you have mentioned about the COBAS PCR.
Yes, I have mentioned about that.
Okay.
It's not an NGS.
It is not
It's
NGS.
not an NGS.
Yes.
And that's
So-
what normally happens.
Yes, so and when you are doing on COBAS versus other kit-based method, I'll rely on the COBAS PCR report because it has some inbuilt cutoff value
Okay.
to take it whether it can be positive or negative. So since it has detected, it is 100% that
Awesome.
it is a
The
report.
question is, can it be,
before Amol comes up,
can it be false positive? Man,
So,
what you're saying is
okay.
it can't be false
Yes,
positive.
It can't be false positive.
I have
Yeah.
a commenter. Yes. Yes.
According to you and the panelists, the labs on which we can trust the liquid biopsy reports. Not all of us have an institution
I
and
will
where
not
we will be
answer
able to
that.
trust.
I will not
So
answer
it is a
That
very
is-
important point that what are the labs? Is there a standardization? Is there an accreditation that this is the lab we should trust and this is the lab we should not trust?
Yeah, if
Sorry.
the report comes positive, you should trust.
No, that is where the
No, no, no,
problem
no.
comes with the report of positive.
No,
I
as I
agree with
mentioned,
you on
but
this.
not
No, no,
based
no.
on the NGS, but if
COBAS.
it is COBAS positive,
Amol,
definitely because
COBAS
COBAS
ki
does.
report, na, my molecular pathologist says that even you can analyze that report. She
No.
sends
Yes,
the
yes,
report.
correct.
COBAS is that easy.
So the
telling you.
question
It is
comes
that
especially for the rare mutations
No.
where somebody
If
lives.
rare mutations, COBAS, so again, COBAS PCR picks up 20.
COBAS doesn't pick
does
up
not
rare
pick up exon
mutations.
20. COBAS will not pick up that.
Yes,
COBAS will pick up
correct.
29 mutations.
Yeah,
Therascreen will pick up only 48 mutations. Rest for everybody, NGS is required. COBAS is the gold standard. If then COBAS it is there, I can show you screenshots. I also see.
now
Sometimes the
again,
But
coming to
can
that
we
point.
have a standardization, a national
Correct.
standardization?
Yeah, I will, Dr. Ullas, now whoever is giving the liquid biopsy report, I've not seen the Garden 360, but I still feel that they should give the tape station peak reports, whether there is not a genomic contamination, or it is a true ctDNA picture.
True. And please understand
yeah.
that, Garden does a liquid biopsy NGS.
Yeah,
This is a COBAS RT-PCR. That's
Correct.
what I have written over here. The liquid biopsy is not PCR only, NGS only. We need as residents, as consultants to understand that. But anyway, so
Thank you.
this study was there, which was done by one of our residents, and that got a DNB accreditation thing also. We compared COBAS versus tissue versus ddPCR, and we found out there's a 99% specificity was very high. The sensitivity of ddPCR was less because it takes only 3, L858R, Del19 and T790. So that was there.
and to mention about this COBAS, our lab was the first to give the license for the
True that,
COBAS EGFR.
absolutely right. So now some more. We got an NGS done, Dr. Sahu. And the report is showing EGFR mutation and MET amplification. That's again a common question which everybody asks us in the WhatsApp group. What to do? What will you do? What will you not do?
Gradually, I don't have this patient on a practice, but if I would, I
Thankfully.
probably would go for a combination at this point, although level 1 is missing. We have case reports and I gradually feel that targeting both might make a difference and you have trials coming up.
What do you do?
What I would do?
What do you do? So I'll tell you, do you give osimertinib or single agent? Do you give OC plus savolitinib? Do you give KN regimen? You know what is KN regimen? You know. Just for the benefit
Kumar Naroha.
Kumar Naroha regimen. That's a TMH regimen.
I know
Let's
that.
not reach them at least. We should make it more forward.
So practically, I would use 1 and 3.
It's okay. That's absolutely okay. Kumar is more senior. That's the only thing. This only Amol can ask.
Okay, so I somehow feel convinced if I have access to the combination, I will do that.
You will do KN.
But if I don't, I will use the third one.
Okay. Anyone else over here?
Yes, at the moment, I don't think that's a very reliable biomarker. I would probably add the KN regimen.
Okay. Anyone? So we again, at present, there is no reason these people behave badly. But right now, please follow your current practice. You don't need to change your treatment right now over there. Now, let's say this patient has got a EGFR mutation along with PIK3CA and P53 mutation. Will you change, Abhishek? Same patient, except for MET amplification, you have got a PIK3CA or P53 mutation. And this is what exactly I call a co-mutations. I just imagine one person center is a EGFR, remaining everything is a co-mutation over here.
Sir, P53 and PIK3, they are the poor prognostic markers. So definitely, theoretically, we should add on
What will you do?
chemo plus TKI.
Chemo plus TKI. Where is the evidence? See, the point over there is we all know it's a poor prognostic factor. So the point is a PT3N3M0 after in CA breast 4AC12T, you give palbociclib and Femara, it didn't work. It's a poor prognosis, absolutely right. But where is the evidence that having a chemo and a TKI works on this? I mean, that's the only question I'm asking.
There is no data for
There
this.
is no data for that. Anybody else, Ashish or somebody from this side? So again, these are poor prognostic things, but whether changing treatment right now helps or not, we don't know. So follow your own practice in this and let the, and then see what exactly happens on that. This is a study which was presented by Dr. Abhinav at ISMPO. We again analyzed our retrospective data of, I think, 200 odd patients. And what we basically found out that the most common mutation was TP53 and PIK3CA. And people who had co-mutations did far worse than what, the other people did. It will be worthwhile doing a randomized study, jinke paas co-mutation hai, and then compare this versus that. But at present, there is absolutely no data to, it's a bad prognostic factor. Whether it is a predictive factor for the KN regimen or an osimertinib or that, we exactly don't know actually about that. The last one, somebody comes to you with yeah, please.
Usually, sir, P53 mutations, they are the marker for progression of disease. So initially we can start with the TKI also, I mean, depending on the, and if there is progression, then we can add on things.
Fair enough. Absolutely right. We can do that. So the next one is, how do you manage a leptomeningeal meds? Somebody comes to you with a leptomeningeal meds. Now, do you give OCAT? I told I will not discuss normal gefitinib osimertinib today. So the last question, somebody comes to you with osimertinib with the LM meds, and what do you give? OCAT, OCAT-BD, any TKI plus MTX, KN regimen and IT-MTX, IT pemetrexate, what do you do? And the answer over here is, मैं क्या करूं, job छोड़ दूं? And that is what exactly I feel, when an LM, and at least I don't know about you guys, for me, LM meds comes into crops.
So that's such a bad situation. If you don't, you have to throw everything at the time. So I mean, just this week, I think we saw a chemo plus gefitinib study in only brain met patients, and it improved overall survival. So and then we also know IT pemetrexate is so good. So I would probably want to combine everything, including osimertinib.
We have again published, yes, Dr.
At this point, what I would do is probably osimertinib. There is also some data on a pulsed erlotinib. It's although toxic. I know it's toxic. I've tried one. It went on for 3-4 months and then we are lost out. So these are two chemo plus IT, the KN with other things come in every time.
Okay. So I think.
So what would you do?
I would give osimertinib 80 mg OD. If the patient tolerates it, fine. I do increase to 80 mg BD. We have got around 20-25 patients, and the median PFS is at least in the range of around 8 to 10 months. So it's LMS with 8 to 10 months is absolutely fantastic. Actually.
If I can ask a question. I mean, is 80 BD actually necessary? The other day we were having discussion.
No, 80. I start with 80 OD.
Because even the dose finding studies of OCE, 40 also is a good enough dose.
So I start with 80 mg OD. If the patient tolerates and if the patient progresses on 80 mg OD, I make it 80 mg BD. 70% of our people are not able to tolerate 80 mg BD. What I do is 80 mg, 160 mg. That is more from my own side. Ki bimari birthday kuch to karo, but nothing really happens. Yes, Dr. Howard.
What two, three things I want to ask through you to this. With that 80 BD, I had a documented Steven Johnson's with osimertinib. Have
And see the liver also.
yeah. So how many percent of patients osimertinib, the original one? It's again the original osimertinib. You have documented Steven Johnson's.
I have not seen, thankfully.
Okay,
I have not seen, but liver
seen
toxicity is something that I have seen.
SJ, I have seen.
One more important thing about osimertinib is
Second,
please look at the DVT, pulmonary embolism, and the heart.
Uh,
10% of people will have some cardiac dysfunction.
if the combination which you had the capmatinib, let's say, or worse, if you have a co-mutation, how many in the house would love to, if they have access to the combination, to start? All those level is
I will
evidence.
give an answer for that. There was a study called a Savannah study and CUC study. After osimertinib progression, you combine osimertinib plus capmatinib versus only capmatinib. The median PFS was only around 6 to 8 months. So it is a very well lucrative thing. We had one patient on osimertinib progression, ALK. We gave osimertinib plus alectinib also. Again, the PFS around 5 to 6 months. Amivantamab, and that is what I showed you over here. Mariposa 2 trial is a beautiful drug, and that is what is supposed to act. So with this, thank you. I hope the thing was interesting and we didn't get bored. Just to conclude, EGFR mutant non-small cell lung cancer is a heterogeneous disease. Many options are available. Liquid biopsy is a very informative tool in the treatment. But we have miles to go.